Good evening. This is Dr. John Shepard and Karen Spencer from Virginia Eye Consultants. We're very pleased to bring to you tonight our approach to the Comprehensive Dry Eye Center of Excellence. We're very pleased to be sponsored by Science-Based Health, and we hope to share with you some pearls, some clinical, and some business insights. Tonight, we'd like to review many of the things that have made our practice grow so rapidly. Now in a 34,000 square foot facility with 12 doctors, 35 exam rooms, a full-time clinical research staff, and 3 operating rooms. It's been exciting to see our practice grow, and the centerpiece of that growth is taking part in clinical research and taking care of high-volume, high-demographic clinical conditions. As part of my professional disclosures, I am a consultant, advisor, and a clinical researcher for Science-Based Health. But tonight's discussion is strictly my viewpoint and Karen Spencer's viewpoint regarding building excellence in clinical practice and specifically in the dry eye practice. We find that when performing clinical research, we can advertise for dry eye volunteers, and we find that we get about 90 phone calls with a single newspaper ad, and about 60 of those patients will show up, and about a third of those will be eligible for clinical trials, but many of them will have refractive eye disease, glaucoma, and cataract. So there's such a common thread in patients who have dry eye, which goes by so many other names, that they too present not only with a center for business in the dry eye realm, but throughout all of ophthalmic eye care. Now, dry eye is extremely prevalent. It's more prevalent as the patient ages. It's more prevalent in women, especially in the younger age groups. And most importantly, and to many folks not realized, is that 78% of cataract patients have a dry eye, 33% of LASIK patients have a dry eye, and 40% of all contact lens patients have a dry eye, according to reliable peer-reviewed studies. This may vary from practice to practice, but dry eye impacts the success of the treatment and the outcome in all of these patient groups, and therefore the growth of the practice. I find it incumbent upon the clinician to make this diagnosis from the very beginning of the evaluation of a cataract, refractive, or contact lens patient. Dry eye is underdiagnosed. Of the 55 million or so dry eye patients in this country, only about 30% are fully identified by their eye care provider, their optometrist or their ophthalmologist. So we are looking always for these patients, and many times the young lady who's bringing in her mom for a cataract evaluation is the dry eye patient who doesn't realize that her disease is just beginning in the perimenopausal phase. We can build this practice based upon symptoms which are highly variable, and many patients aren't sure that the symptoms they're seeing or feeling have something to do with dry eye because they're totally unaware of the diagnosis, and the symptoms and signs may not necessarily correlate. The etiology of dry eye is multifactorial and overlaps with allergy and blepharitis, 2 other extremely common ocular surface diseases. However, the underlying core of dry eye, as seen in this lacrimal gland biopsy, is lymphocytic infiltration. And in centuries past, a simple biopsy of the minor salivary gland in the lower lip revealed this pathology, which was parallel to the pathology in the lacrimal gland. So an autoimmune context is well accepted. And we see this also in biopsies of the parotid gland, indicating that in, for instance, Sjogren's syndrome, dry eye and dry mouth or xerostoma may be concomitant. Here we see a biopsy from the Flugfelder lab at Baylor showing the expression of HLA-DR and CD11, which are markers for ocular surface inflammation, and an impression cytology specimen from our clinical trial. So clearly this is discernible from average patients with average complaints, and this worsens with time, with age, and without intervention. So in this multifactorial etiology, we have to respect the patient because they may have some or all of these etiologies in different combinations. And it's the task of the clinician to dissect and analyze these etiologies and to intervene at the most appropriate phase. And I try in every clinical circumstance, unless desperate, to make one intervention at a time under a controlled situation and observation period by both the doctor and the patient to see if the signs and the symptoms improve with a single intervention. This way we can be most objective in our analysis and truly evaluate what we recommend for our patients in a scientific manner. So the tear film is truly a delicate balance. It needs to be healthy to contain the proper proteins and the immunoglobulins for building epithelium and protecting from infection. This balance includes the outer lipid layer, the aqueous component, and the inner mucin layer. And this entire tear film is the refractive surface of the eye. Any disturbance will not only affect visual clarity and higher order aberrations, but also the predictability of a refractive or cataract surgery, where these surface measurements and keratometries are so critical to best calculating the outcome. I find this the most common problem in refractive cataract surgery patients is undertreated or ignored diagnosis prior to obtaining lens calculations of ocular surface disease and dryness. And these erroneous calculations produce unhappy patients with over or plus minus outcomes in their cataract surgery, or aberrations that are completely unacceptable to the multifocal lens patient. This is clearly an area where all of eye care needs to improve. So we need to make a diagnosis of dry eye, and we can use this with the traditional methods of lissamine, rose-bengal, or fluorescein staining, or with the traditional Schirmer's test. And I think staining is very important. It shows us the location of the irritation and particularly identifies central corneal staining. These are patients who truly need intervention prior to the cataract or the LASIK evaluation. The Schirmer's test is useful when it's very, very low, because you know this patient has a severe tear deficiency and will respond aggressively to punctal occlusion therapy, conserving that highly deficient tear volume. Fluorescein staining shows us basement membrane and dead cells, and rose-bengal staining shows us denigrated and dying cells, as does lissamine staining. And there may be an imbalance between corneal and conjunctival staining, but it is that refractive surface on the cornea that is so important and is so importantly analyzed by the FDA in clinical trials for pharmaceuticals, so highly sought and coveted as viable intervention strategies for dry eye. We all know that this has been a challenging market for a wide variety of well-managed and scientifically grounded companies attempting to get a new topical agent approved for dry eye disease. We can grade corneal staining by zone and by intensity. This is the NIH scale, and it is very useful for the clinician as well as for patients who are undergoing clinical trials. A uniform amount of fluorescein should be placed in the eye, usually with a fluorescein strip in the clinical situation, but it is important to wait about a minute or two, if possible, after instilling the fluorescein, because so much more staining will light up after waiting. And this is a good thing to do after pressure checking, and it's very, very important to document this on the chart and have a uniform scale not only on the doctor's own charts, but in the practice, so that interphysician as well as intraphysician observations remain consistent. And I always like to look at the central and the inferior staining, and here we see various degrees of staining. Clearly, a patient with grade 3 staining is not a candidate for any elective surgery, nor for successful contact lens fitting. Grade 1 staining generally improves more rapidly with the initiation of therapy. A more objective means of testing for dry eye is office osmolarity testing, brought to us by the Tear Lab company. This is a very quick test. All of our technicians know how to perform it, and it is billable and reimbursable by most insurance companies. But you have to be careful in your marketplace, because there will be underpayers and overpayers. This is no longer necessary to obtain a CLIA waiver, and it is a very, very user-friendly test that gives a patient a number to look at and seek improvement for, just as they do their intraocular pressure or their cholesterol or blood pressure. A very, very powerful tool, and it tells us that very high readings and very disparate readings between the eye are an indication of dry eye. This is a gold standard, if you will, and it is the only truly numerical test that we have. If you look at the positive predictive value of osmolarity testing, patients with a osmolarity greater than 308 have an 87% chance of truly having dry eye. and this is comparable favorably to the other standards that we use for the evaluation of dry eye. Obviously, a wide variety of methodologies are utilized, but this ANOVA, or analysis of variance test, comparing severity and osmolarity to other signs obtained in the examination, show a pretty good linear regression analysis when we compare the severity to osmolarity. The scatter is minimal and the standard deviation is low compared to other testing methods. So we look at the scale and we use 308 as the initiation of mild dry eye, and higher numbers indicate more severe disease. And I have seen countless patients improve with nutritional therapy alone, with anti-inflammatory therapy alone, and with punctal occlusion alone, or in combination, obviously, along this scale, giving both the clinician a degree of reassurance and the patient a degree of satisfaction that truly their symptomatic improvement is objectively documented. Other companies, such as Lacroscience, are working with contact osmometers that may even more improve the simplicity and the rapidity with which we can obtain this test. We look at current dry eye therapy, and we're very pleased to offer patients a wide degree of treatment modalities as well. If we look at the level 1 through 4 modalities, these have been created by the Dry Eye Delphi Workshop, or the Dry Eye Workshop, a collection of experts that came up with this new classification. And they introduce various levels of treatment along that spectrum. And we see at level 2, which is the very beginning of consistent symptomatology, that anti-inflammatory and nutritional support are clearly recommended. And we in our clinic are very, very eager to produce that intervention at the early stage, remembering that cataract surgery will temporarily add a level and that LASIK surgery will temporarily add 2 levels to the patient's degree of dry eye. So you've got to get this stuff controlled early rather than late. Now, we have 2 best-of-class anti-inflammatory treatments, loteprednol and cyclosporin, with which our staff is highly familiar and our pharmacies are very readily capable of providing these favored medications. And we look at humans, and we can see that in the Restasis trials, even in non-Sjogren's patients, that over 6 months of Restasis therapy, a tremendously statistically significant decrease in the expression of conjunctival biopsy T3 and CD3 cells were very much improved, and that's exciting. We actually took SNP biopsies out of the patient's conjunctiva in the clinic with local anesthesia. My preferred therapy is induction with Lotemax and maintenance over the long term with Restasis. We have samples of both in the practice, and we instruct our patients on Restasis therapy, removing the cap of the bottle. In the dry eye pipeline, there's truly a wide variety of products that intervene in every stage of this multifactorial process, be it tear film instability, mucus insufficiency, and there's a couple of drugs in phase 3 trials for mucin, secretagogue activity, and decreasing the sensory response and other environmental factors. So the desert surface of the dry eye patient is clearly amenable to a wide variety of therapies which interdigitate with one another. And with our improved diagnostic capabilities, we can get the right patient on the right therapy at the first visit to our office. Now, the pipeline is really exciting because there will be other anti-inflammatories, there will be secretagogues, and there will even be human recombinant protein supplements placed on the ocular surface to provide synergistic improvement in the patient's dry eye. 15 years ago, we just gave the patients a bunch of tears with preservatives and said, I hope you get better. Now we have a very nice diagnostic algorithm looking at the difference between evaporative and a hyposecretory dry eye, and we can splice through the different mechanisms to best produce an outstanding result for our patient. And our library of interventions will increase tremendously in the next 5 years. So hopefully we won't be seeing the stage 4 moribund dry eye with filaments and significant transient visual loss and loss of time in both activities of avocation and advocation. And the patients who present to us will be at an earlier stage and amenable more rapidly to therapy. We have another interesting test from RPS called the Rapid Pathogen Screening Direct Lid Assay of Matrix Metalloprotease 9. This is an inflammatory marker, and this test simply gives you on a pregnancy-like strip the adequacy of the test with the red stripe and the positivity with the blue stripe. And a certain level is a yes, no for the dry eye. So this is another quick method that we can use to look at anti-inflammatory activity in the ocular surface as well as osmolarity. Now, we used a lot of these tools to look at the long-term, that is 24-week supplementation of a very discrete group of commonly dry eye patients, that is the postmenopausal female, with a nutritional intervention created by Science-Based Health and now marketed as Hydro Eyes. And we look at our core therapies for the dry eye treatment paradigm, and we can start in milder cases and advanced cases as well as future cases with nutritional therapy because of its tremendous safety and its low cost. There's really nobody who doesn't deserve this type of therapy. So we looked at the long-term supplementation of the N6 and N3 omega-3 acids and the various types of anti-inflammatory properties of these essential fatty acids found in the Hydro Eye formulation. And basically it's GLA, gamma-linoleic acid, and icosapentaenoic acid, and dihydroicosapentaenoic acid. And these fatty acid supplements are very, very effective alone, and now we found in combination against the dry eye inflammatory process. We looked at 38 patients in the control and the treatment trial, and both arms were watched for 24 weeks. And we'd hoped that this supplementation would improve the inflammation as well as the symptomatology and the ocular surface regularity using these essential fatty acids. These polyunsaturated supplements have been looked at in a number of studies previously in the peer-reviewed literature. In this particular group of slides, we see a non-controlled study and an observational study in moderate-sized groups of patients who improved with omega-3 and omega-6 fatty acids in terms of a conjunctival HLA-DR inflammatory marker, and that omega-6 fatty acids showed decreases of levels of prostaglandins on the ocular surface. In the next group of studies by Berabino in Italy, his Geneva cohort showed that GLA therapy alone improved the HLA-DR markers on conjunctival cells using brush cytology. And this was a prospective trial published in Cornea. The TheraTears group is a proprietary group that allows, through their advanced tear science marketing mechanism, patients to use a variety of tears, a variety of supplements, and lid scrubs. And they showed in their trial that 70% of the treated patients became asymptomatic, while only 7% of the placebo patients became asymptomatic. But if you look at the data more carefully, there was no statistically significant differences in the group, and 100% of the placebo patients did improve. But this was a step in the right direction with 36 patients who completed the study. In our trial, we looked at 6 primary endpoints. We looked at Schirmer's, the OSDI, breakup time, and various stains, and of course impression cytology, as well as secondary endpoints of comfort levels, tear use, and the ISIS Topographer 2000 Ocular Surface Regularity Index. And we use Hydro Eye. We use the standard dose, 2 pills twice a day. You can get this in your office. We sell it at the front desk. You can use an 800 phone order, and you can get it on the internet online. And Karen has been instrumental as the CEO of our practice and running all of the very intricate business aspects of a practice with 115 employees and 12 doctor providers, 2 optometrists, and 10 ophthalmologists. And we found a pretty straightforward way to get this Hydro Eye to the patients. In fact, I'll have patients drive into the office just to pick it up, even when they don't have a visit. And Karen, I think we've had pretty good success getting this to our patients and not disrupting patient flow.
Yes, sir.
And I think our modus operandi is a checkbox on the discharge form, and when the patient checks out, the young lady making the appointment for the next visit allows them to pick up the Hydro Eye. It works very well, and of course this was given in a masked form in our study. And here you see a list of the ingredients for the Hydro Eye, which have been created with close attention to the peer review literature. So we looked at postmenopausal females in our clinical trial, and we looked at the bottom group of fatty acid dietary intake. So we didn't look at people who were already taking 20 fish oils a day and 75 different vitamins. We looked at people with a below average diet, a busy lifestyle, and who had moderate to severe dry eye, and some evidence of meibomian gland dysfunction, and a Schirmer's below 10 is the inclusion criteria. So we screened about 48, and we got about 54 consented. We had some screen failures and withdrawals, but we finished with 20 patients in Norfolk and 18 patients at Baylor in Houston. And we looked at our OSDI results, and we were very pleased to see that there was a clear-cut separation from the beginning, which achieves statistical significance at week 24. And this was the global OSDI, all 12 data points. And this was done, obviously, in masked fashion, both by patient and the clinical research staff and the doctor observer. Very pleased to see that there was clearly a difference in the OSDI for these patients. Very exciting data for us. And this was significant also at the non-normalized data at the 12-week point. So we had a lot of excitement over this data in the 34 patients who gave us the normalized data and the full completion, and the 21 patients who went on to show that they had markedly improvement in their symptomatology at the end of the trial on our substance, which was found to be hydroized. So we looked at targeted inflammatory markers as well, and we looked at ocular surface dendritic cells, HLA-DR cells, and of course CD11 cells, which is integrin and activates white blood cells, and it's a very specific conjunctival subset for T-cell activation and antigen recognition. And these are well known to be upregulated in the dry eye patient and in a number of other aging conditions. To be brief, we took a conjunctival impression cytology, saved it at room temperature, fixed it, and then sent it to Dr. Flugfelder's dry eye lab in the Ocular Surface Center at Baylor. And he was able to take an average subset of 5 different pieces to get a statistical average and look at the way these patients' surface is stained. And here you see a control patient who actually showed continuous worsening of the expression of these inflammatory markers in their conjunctiva over the 24-week course of the study. So we look at HLA-DR, we see that in a way the patients on the hydro-eye pretty much stabilized the expression of these markers, whereas the patients who were on the placebo showed progression and worsening of both the HLA-DR and the CD11 markers. So what we're seeing is without the supplementation, the normal aging process continues, just as we saw in the Restasis trial 12 years ago. And without interrupting that process, these patients continue to age. They continue to express more inflammatory cell surface markers on their conjunctiva. So this data was truly impressive and truly showed us that at both the 12 and 24-week time point that this cell surface inflammation worsened with time without proper supplementation. Very exciting beginning to the anti-aging process of intervention and prolongation of life systems in every one of our important organs. The one mechanism that's been shown over time to improve longevity in a wide variety of animals, from nematodes and single-celled organisms to primates and humans, is caloric restriction, reduction of the number of calories that go into about 20% below perceived desire in the human. And we see that patients in Okinawa, for instance, not only have a decreased caloric intake, but an extremely high intake of seafood. And these are the longest-lived persons on the face of the earth. So there's something to be said for a high omega-3 intake and caloric restriction. In addition, in our patient cohort, we looked at digital topography, and lo and behold, the surface irregularity index was improved in the patients who went on the hydro-eye. And this is very important to the refractive surgeon, very important to the refractive cataract surgeon, because the better lubricated surface, the more balanced tear film, the better nourished patient will have a smoother ocular surface, better outcomes, and better predictability. We were frankly surprised at this particular significance because we made this a secondary endpoint. This data was first presented at ARVO last year, and the poster was sponsored by both Science-Based Health and the Virginia Eye Foundation. So the summary tells us that the supplement treatment in postmenopausal women with moderate to severe keratitis sicca for 6 months yielded significantly improved OSDI scores, a significant suppression of biomarkers of ocular surface inflammation which progressed in the untreated patients, and a significantly maintained corneal surface smoothness. And we published this in the August Cornea. It was the lead article in that journal. And with this publication, we hope to disseminate this knowledge of finally a peer-reviewed, prospective, randomized, masked, multi-center study with laboratory confirmation of true improvement of the ocular surface in patients who take proper nutrition. This is very exciting. It tells me also that the omega-3, the DHA, EPA, as well as the GLA intervention will improve things. So I'm very, very proud of this data. We're somewhat very, very interested to realize that we can produce such significance in such a small population. And the reason this was achieved, I believe, is that it was a very narrow population. These are somewhat nutritionally challenged women who were not in the top quartile of excellent nutrition, but they were normal average patients with normal diets otherwise. And they were patients who did not regularly eat large amounts of seafood. Other than that, they were postmenopausal, and they were willing to be in the study. So this is the core of my population. This is the refractive cataract population. This is the young lady who brings in her teenage child to evaluate for contact lenses, and then bring in her college graduate child to have refractive surgery. These perimenopausal females are the decision makers in the healthcare process in this country, and they are the focal point of any marketing plan to grow your practice and any educational process that occurs in your patient base and in your local community. So in our particular practice, we have an academic mindset. We do clinical research. We're very pleased to do clinical research. We're pleased to relax in the evenings, and there's a beautiful night over the Chesapeake Bay tonight. We're having some pretty good weather here in the Norfolk area, but I'll tell you, the hygrometer is going down. The mean humidity in this area goes from the 90s in August down to the 40s in the fall, and with the heat on, down into the 30s and the 20s indoors. So we're coming upon this particularly dry eye season, and as a result, we are going to be more challenged. We're going to have more patient referrals for dry eye and more patients coming in with ocular discomfort who don't know they have dry eye. So we've been very, very rewarded by building our dry eye practice and now focusing the entire concept on a dry eye center of excellence. And I don't think there's anybody who is more qualified to discuss building a practice, building a medical practice, building a surgical practice, building a clinical research practice than Karen Spencer, who came to us from Colorado, really, 5 years ago and has been instrumental in helping us to grow on a very consistent basis. Karen was instrumental in helping Virginia Eye Consultants to be named one of the top 7 small businesses in the country by the Chamber of Commerce, and to be one of the top 20 growth businesses in any field in our metropolitan area for 2 years running now. So, Karen, I'm very proud to introduce you, and I think you can give our audience some insights into the business aspects of building a dry eye center of excellence.
Well, thank you, Dr. Shepard. I appreciate the introduction, and thank you all for joining us this evening. My job tonight, I think, is just to bring into place some practical considerations and strategies for developing a dry eye center of excellence in your own practice. And I'm going to share with you tonight the process that we at Virginia Eye Consultants went through as we were considering how can we really take our dry eye clinic to the next level. And we went through some bumps and bruises along the way, just as many of you have or will in your, strategy to move forward with your dry eye care in your practice. So I'm going to start off just by saying that I think the number one issue, and for those of you listening, obviously this probably isn't an issue for your practice, but you really need that commitment from the top. You need a physician champion, somebody that's really going to drive all of these principles and the strategy for the dry eye center of excellence in your practice. And that needs to come from the top, like I said, from the from the MD, champion, the practice administrator, CEO, and really some true key staff that are going to kind of cheerlead the process and ensure that the remainder of the staff jump on board and are really on target and on point with where we want to head. So really we approach this similar to the way we would approach anything that we're adding to the practice, and we really took a strategic planning approach and looked at what is it that we really want to accomplish. So we took a peek at where we were, our current volume of dry eye. We have a very high volume of pathology in our practice. We have a very strong cornea practice, and so we found that a very high percentage, upwards to about 60% of our patients currently within the practice were dry eye patients, true dry eye patients. And so we had a very high volume just internally, not to mention what could potentially be out there that we hadn't touched yet or that hadn't come through the doors of our practice. So we kind of thought that, hey, we've really got something here, and with the current technology, all the new technology that have been being developed between the Tear Lab, osmolarity testing, LipiFlow, I really had an opportunity to take a look at something that was more cash-based that we could really truly amp up in our practice. And as everybody knows, with declining reimbursements, with some of the challenges that we're all facing in our practices from an insurance perspective, this is a really nice kind of adjunct to some of the other things that we traditionally do in the office. So we took a look at, between our current volume, what we really wanted to accomplish in the new technology and the new products we wanted to incorporate. We actually had been providing an opportunity for patients to purchase nutraceuticals and some lid scrubs and some other things in our practice from a kind of more retail perspective for quite some time. But we really had kind of been sitting in the sidelines a little bit and looking at Tear Lab osmolarity, for instance, for probably several months when it first hit the market, and really tried to take a more conservative approach to integrating that into our practice. When that technology first came out, there were some CLIA issues in terms of the type of CLIA certification that was required for that technology to be implemented in your practice, which required a little bit more of kind of a lab setup, which we were not confident that we really wanted to move forward in that direction. And so until the CLIA waiver was approved for that particular test, we sort of sat on the sidelines. But once that happened, we sort of started thinking, okay, it's time to dabble into that. And once we did that, we brought one unit into each of our locations and tested the waters in terms of reimbursement on the insurance side, and wanted to make sure that before we moved forward, we really had a solid plan and that we knew we were going to get paid for the services that we were providing. And then once we realized that we had a strong potential there, we went ahead and moved forward. And so now we have about 6 units through our 2 offices, and we're getting ready to bring another office online in the early part of 2014, and we intend to add probably 2 to 3 units at that office too. So that's become part of what you'll hear in a few minutes as our dry eye protocol. Other things to consider in the strategic plan clearly are your market and your competitive analysis, and really setting yourself, how are you going to set yourself apart as a dry eye leader in your community? What are the things that you can do that are different from those of your competitors? And so that was a strong consideration. Other things to think about are historical patterns of provider adoption of new technology and changes in practice patterns in your practice. And we are a large group. We have 12 providers, and so there's varying levels of adoption of new types of practice patterns. There's varying levels of adoption of new technology, and we had to really consider that, because some of these new technologies, particularly the LipiFlow, is a strong investment for your practice, and you really want to make sure that before you move forward with something like that, that you're going to have some good adoption and that everybody's on board with that. And again, kind of going back to my first point, that there's some strong commitment. So moving forward from there, another component of the strategic plan is really feasibility. And so this is really breaking it down to your cost-benefit analysis. If we're going to put out the money, we're going to buy the inventory, we're going to purchase the equipment, we're going to purchase the click fees, the cards, et cetera, that are required for the various types of technology that we're acquiring, and where are we going to break even, and where really is our sweet spot, and can we get there, and can we get there comfortably and feel good about that? And so I think, that's a key component And if you don't have somebody in your practice that really can help you work through those fiscal numbers, I highly recommend that before you move forward, particularly with some of the more high-end technology, that you get somebody on board, whether it's your CPA or somebody that can help you work through those numbers, because you really do want to make sure that you're going to retrieve some return on your investment. We do want to have quality of patient care and be able to provide a menu of options for patients, but we also need to be smart about it in this day and age, so something I would really strongly recommend that you do. Next is your retail strategy, and really taking a look at what can you do internally and externally to provide some retail space, to look at displaying, to look at how are you going to display your nutraceuticals, how are you going to display some of the products that you are going to have available for sale for patients, and really allowing them to touch it, to feel it, to have it kind of engage them a little bit in the process when they're sitting in your waiting areas, whether that be up front, whether it be in your dilating area, having some opportunities for streaming video in your waiting areas and your lanes, and really looking at ways to advertise that not only just internally but externally, and we'll talk about that in a minute. We're also looking at some ways to engage e-commerce with our patients, with the smartphone technology that's out there now and the barcode apps and things that you can have on your phone. There's some real opportunity for patients who are looking at things in your waiting area to be able to scan their phone over a barcode and be able to even just purchase those items right away as they're sitting in your lobby with, a few minutes to spare before they're taken back for the workup. So really something to consider in that retail strategy. Next is your clinic protocol and your workflow analysis, and this is really the crux of, the internal operations of your practice and how you're going to make this successful. A couple of the things that we really looked at were, do we want to incorporate this into our traditional clinic and just have it be as it has been, which is just a more traditional part of our regular clinic with a dry eye patient, or do we want to have a specified date and time where we have, dry eye patients coming into the clinic and we're working with them in more of a secluded, kind of more spa-like environment? And although the second option seems a little bit more idealistic and probably a little bit more attractive, on some level, we found it a little bit unrealistic to be able to actually implement. And so we have went both routes and have determined that it was best for us to, at least at Virginia Eye Consultants, to incorporate that into our traditional clinic. We see approximately 250 to 300 patients a day in our central office, and so trying to kind of divide that and make that work within the space constraints that we have was a little difficult to do. So we did incorporate that ultimately into our traditional clinic, but there are obviously several ways that you can do that. One of the key things that I think that has really turned the tide for us in terms of identifying dry eye patients is we provide a speed questionnaire to every patient that comes in the door, whether they're new, whether they're established, and we give it to them every time that they come in, unless they've been identified as a patient who really has a low score and isn't a dry eye patient, and those are all done through the alerts in our EHR system, and it's very obvious to identify patients who don't require that speed. But that's really a great marketing tool, because there you have a score, you have, some information about that patient and their symptoms prior to even the tech taking them back and taking a med history and a chief complaint. And therefore then that tech who's looking at that speed questionnaire, who sees a score that's within range, can really start chatting with that patient about the symptoms that they're seeing on that speed questionnaire and work that dry eye complaint into the chief complaint if it's feasible and if it is realistic to do so. In our particular environment, after that speed questionnaire is reviewed, of course, the tech does the basic workup, and we do a tear osmolarity on any patient who looks as if they are even borderline dry eye. There's, of course, an ocular surface evaluation done by the provider, which includes a lid assessment, gland expression, and some additional testing to include an IOP and Schirmer's. And then once the provider is done with that exam, including the dry eye evaluation in addition to any other complaints that the patient has, if the provider determines that that patient truly is a great candidate for any of the dry eye products or technology that we have available. In our practice, we've opted to have that patient referred then on to what we have called our dry eye counselor. And we have treated that physician similar to that we would treat a LASIK counselor, a premium lens counselor, and it really has become a very integral part of our dry eye treatment at Virginia Eye Consultants. And I'll talk a little bit about that in a little bit, in terms of the types of traits that you want to look for in that person and how you can kind of incorporate that, even if in a smaller practice you don't have the ability to actually have a single person that can kind of take on that role. But you do need a staff champion and someone who really believes in it and who's going to help that patient kind of believe in it as well, particularly if the provider believes that that's the best route for that patient to go. So once the counseling process takes place, we clearly schedule the patient for treatment. We do provide the patient the opportunity to have treatment that day, and our dry eye counselor has the ability to go ahead and push that forward. We have several physician champions in our particular practice who are willing to jump in at a moment's notice in between patients and be able to greet that patient and ensure that activators are placed if they're going forward with the LipiFlow treatment, et cetera, and be able to push that treatment forward. In addition, if the patient is not a LipiFlow candidate or opts not to go with the LipiFlow treatment, we have a plethora of products that the provider typically will recommend in lieu of that or in addition to that. Patients in our practice who do move forward with a LipiFlow treatment receive a spa bag, which we also call a maintenance bag, and it's kind of a gift bag. I have a sample of that in my slides, which I'll show in a little bit, and it has various products in it that we kind of encourage the patient to continue to use to augment the treatment. And then in addition, we sell that as a package and individually, of course, for patients who either opt against the treatment or who really don't need the treatment but just need some additional assistance, and I'll talk about that in a minute. The next thing to consider, and this is something that we really had to put some strong effort in, is provider and staff training to include follow-up and accountability. And this is where I'm going to talk to you a little bit about our dry eye counselor. But truly, we had some dry eye champions from across the country, some strong MDs who had really kind of been thought leaders in dry eye come into our practice. And we feel like we're fairly sophisticated in our process, and we have some pretty world-class physicians in our practice, but we certainly felt like we can always learn from the best. And so we took the opportunity that was presented to us from the various vendors and had MDs come in and actually talk to our MDs about how these successful practices have incorporated the technology and incorporated these products into their practices. And it really helped us to kind of catapult the process forward because we didn't have to reinvent the wheel. We didn't have to kind of think through these processes ourselves, and they brought forward some ideas that they had already kind of went through the trial and error process on. And so for us, it was very timely, it was very helpful, and it really helped kind of get the providers on board with, hey, here's this person that I think a whole lot of, that I think highly of, and they're telling me that this is how they're doing it. And so we were able to really kind of get the physicians on board, and in addition, included the key staff that were going to be involved in those processes for training with the providers. And so together, they really kind of came up with some great plans. We sat afterwards and we would strategize in terms of how we wanted to incorporate the ideas and the things that we gained from those visits. And then we put it into place in our practice. But one key area that we really felt was critical was incorporating a dry eye counselor or somebody that can coordinate that process for you, so that staff person champion, that's kind of that key person or few people, depending on the size of your practice, that can really talk to patients and get them excited about some of the options that are available to them, because there really is some great technology and we really can help these patients. And through all of the products that we're able to provide, and particularly the technology, including LipiFlow, we can really make a big difference in these patients' lives. And so we really want to make sure that the patient knows what's available to them and that we really can help them before they leave the doors of our practice. One of the things that we looked for, well, several of the things that we looked for when we were thinking that we needed a counselor in this position were, we knew we needed somebody who had a little bit of marketing and sales background. This isn't something necessarily that you can take a technician and turn them into a counselor. Technicians have a technical background and they certainly have the knowledge base to do that, but they really have to have the ability to have a little bit of more of a fact-finding, relationship building, rapport building, type of personality, and they need to be a little bit tenacious and somebody who can not only be a caretaker and educator, but really somebody who can be a closer in terms of, helping the patient get to the decision if they're going to move forward with purchasing products or if they're going to move forward with treatment. And so, we really, honed in on a few members of our staff who had those personalities, and we really picked in our practice, we already had a model for that between our refractive counselors and our counselors that we have in the premium channel for our premium lenses and our laser cataract department. And so we were able to really kind of hone in on that group and kind of add this as an additional opportunity for learning for them and an additional opportunity for them to gain some incentive in their compensation and some other things. And so we were able to kind of dovetail the LASIK and the cataract counseling into the dry eye counseling, and it's worked well for us. But you need to set your staff up for success. You need to make sure that they're trained. You need to make sure that they have the tools that they need. For instance, we use some really neat apps on the iPad where we have some great graphics and technology that they can provide to patients and really talk to patients as they're counseling them. Each counseling session takes approximately 12 to 15 minutes. And they really spend a lot of time getting to know the patient, really looking at their lifestyle questionnaires, their speed questionnaires, getting a little bit of understanding as to what's driving them, what are they doing on a regular basis, what are they doing every day, and how is this issue that they're having with their dry eyes affecting them. And so those are kinds of, some of the things that we're talking about when we are looking at provider and staff training. The follow-up and accountability is another issue, I think, making sure that you're tracking all of what you're doing. So, you do all the front-end work and you know where you need to be in terms of your number of procedures. If it's a piece of technology, you know where you need to be selling to gain back your investment on your inventory, all of those things. And then you need to be tracking that along the way on a very, monthly basis, maybe even less than that initially, just to kind of make sure that you're keeping the staff accountable to the parts and pieces that they have in this process. And in addition, keep reminding the physicians, which has been a challenge to some degree in our practice as we're incorporating these new practice patterns with our physicians, is to ensure that they're remembering to incorporate this in their daily discussions with their patients, particularly those who have high speed questionnaire scores. And so those are the types of things that we've done at VEC. Moving on to advertising, I think there's several components to advertising. One is internal, and we have such a grand opportunity internally with patients who are, right there. That's a captive audience. We have not only patients in the office, we have patients on hold on our phones, we have patients on the phone. And so what we've done is really kind of taken a comprehensive approach to how we can communicate with these patients and tackle these things for, and kind of get them engaged in thinking about their dry eye disease and their interest and motivation to make it better. So one of the first things that we do is that we have an on-hold messaging system. So when a patient calls into our office and they're put on hold, there's an on-hold message that plays for them, and it plays various things. But one of the key things that we've added to that recently is the type of products and technology that we have for the treatment of dry eye. We've already talked about the speed questionnaire. We also provide some table tents in the lobby We have some great displays. We have a beautiful front lobby that's very open, and we have some nice glass displays that patients can actually touch and feel the products, have an opportunity to ask our front desk staff, who are all very well versed and very well trained in how to sell those products and how to talk to patients about those products, what they are, what their potential is in terms of the treatment of that patient's disease, and then, if there's any specific clinic questions, those things kind of go back to the technicians and the providers, and those don't come up very often at the front desk. But we do take that opportunity while patients are captive in the lobby to really try to advertise to them. In addition, we have patients who are sitting in a lane waiting for the doctor with the door closed. So we take an opportunity to look at the back side of that door and what can we do to engage patients there. So we have some posters and we have some product displays and things like that on the back door of our lanes. Just to try to engage patients and have patients ask questions. Another thing that we've done both with LASIK and now with dry eye is we have little badges. Our staff wear lanyards with their clock-in key and all of those things on them, and they have our logo on them. And so we've given them various badges if they have, particular number of years of service, if we're running a LASIK promotion. And now we have some badges that say, got dry eyes with a question mark, ask me how we can help. And it's just another indicator to a patient when they're right there with the patient working them up and that patient's kind of looking at them and engaging with them. It's an opportunity for a patient to see that and ask a question if they have dry eyes. We talked about the video stream in the lobby. We talked about the iPads available. We do have iPads available in our lobby for patients who are interested in looking at patient education while they're sitting there, and we do check those in and out. We have showcasing, which we talked about, and the really neat thing that we've added since we have really kind of made the push for some of the newer technology in our office is the spa bags. All of us girls, and obviously there's a lot of women who have dry eye, we like to go to the spa. We like to take something with us. We like to kind of have that. We love to shop. And so we've really found that the spa bags have been a nice takeaway for some of these patients. We give those spa bags free to all of our LipiFlow patients, and then we have them available for sale also. In the spa bags, we include a bottle of Hydro Eye. We include a tranquilized moisture goggle with some replacement pads, a fire and ice pack, a sample of artificial tears, lid scrubs, and a sample of Lotamax gel if they've had the LipiFlow procedure, just in the event there's any inflammation or redness after the procedure. And then, of course, we include some sort of VEC swag, we call it, and at this time that's a VEC water bottle to remind them to hydrate. External, we have a very strong optometric and MD network outside of our practice where we receive about 65% of all of our business from that network. And so we've taken a lot of opportunity to advertise the things that we're doing in dry eye, try to engage our ODs and participating MDs in the care of those patients and how we can kind of team up together to really work toward creating a better situation for these patients. And we truly have been able to demonstrate that our outcomes with LipiFlow, about 85% of our patients are highly satisfied afterwards. We do give the speed questionnaire, obviously, before the procedure and after the procedure, and we're able, even if the patient isn't feeling necessarily a major change in their symptoms, we're able to show them by their speed questionnaires that their scores have really reduced significantly before and after. And so we've had some very, very good success with that. In addition, we've done some newspaper ads, and there'll be some samples further into the slide set of a couple of the ads that we've done, both in the paper and women's health journals. We've done a little bit of radio advertising, not a whole lot for dry eye. And then we like to participate in any women's health care events. It's October right now. There's a lot of breast cancer awareness things going on. It's a great opportunity just to get involved and really meet that market and that sweet spot in terms of the dry eye population. In addition, spas, health clubs, any place that women in particular are going to be hanging out. And so beyond that, that's really kind of it for us. I've included some examples in the slide set for you of our on-hold message, and that's really our on-hold message. If you call our office, you'll hear that word for word. I've got an example of the workflow for our call center and what they're instructed to do if a patient calls in for a dry eye eval, or if a doctor calls in for a patient and they've already evaluated the patient and want to, have that patient come in for a procedure. In addition, I have there our clinical protocol and our workflow, and we talked briefly about that, but that's the specifics of that. And then I have a few examples of some of the print ads and direct mail that we've done, a picture of our spa bag and what's included in that bag, and that's really it. So I guess at this time, Dr. Shepard and I will take some questions from the audience. There's a Q&A portion at the bottom of your screen where you can submit any questions that you have of us, and I will turn it back over to Dr. Shepard.
Thank you for the outstanding presentation. And the mark of a good CEO is having the figures right at the tip of your fingers. And you need to watch numbers, and it's so important to track items. If you don't track it, you can't modify it, correct it, or improve it. And this is truly a numerical business, just as we look at osmolarity or intraocular pressure and keratometry. We have to look at the numbers we obtain, even in subjective numbers that patients give us, like the OSDI, the Ocular Surface Disease Index, or the Briefer Speed Questionnaire. A couple of questions have certainly come into us, and there's always the concern of the increased risk of lung cancer found in the AREDS trials. And obviously it's beta-carotene that has that association, obviously in smokers. We were clearly not able to assess that in this trial because we were using vitamin A, which has no such association. But the beauty of the quantification of ocular surface disease care now is that we have numbers that we can follow, and we have procedures that we can be reimbursed for, and we have diagnostic procedures that we can be reimbursed for. Now, it's clearly important for us to offer our patients the whole compendium, all of these different cutting-edge components. We are now unencumbered by the Clinical Laboratory Improvement Amendments, the CLIA, because these tests are simple enough to be done at home and therefore don't require this inundation of government regulation, fortunately. So with these added advantages, we can truly bring additional quality of care to our patients. There are some recent reports also in the literature about an increased prostate cancer risk with omega-3s, and unfortunately there's been one study that's completely consumed the news media. And I can certainly tell you that a large number of patients who take high doses or adequate doses of omega-3s do not develop prostate cancer. Prostate cancer is endemic to males in the 60-plus age group. Most of us die with prostate cancer of another cause. So this increased risk is very difficult to assess, and the current diagnostic and testing methods, including the ubiquitous PSA, the prostate-specific antigen test, are falling into disrepute. So this epidemiology clearly requires confirmation, reduplication, and further analysis. I have not changed my recommendations for omega-3 intake, nor do I take any less myself, which is currently at 4 a day. The obvious difference in Hydro-Eye compared to other products on the market is the quality of the product. These are all fresh, off-the-shelf, pharmaceutical grade. What it says on the bottle is what you get, and this is very inconsistent with many of the nutritional industry standards. And being an unregulated industry, it's truly a part of the character of a company to provide reliably reduplicatable concentrations of the various nutritionals in their supplements. The compendium of GLA and EPA and DHA in a pharmaceutical-grade mercury-free product is a challenge to produce economically, and it's only through scientifically driven economies of scale and very sleek and effective distribution methods that do not add cost to the product that this can be brought to our patients at a very reasonable cost. And I've yet to find a patient who can reduplicate the contents of Hydro-Eye and save money. Not to mention that I think if you call the company in Texas and ask for a 6-month supply in the mail, mention your doctor's name, you'll get that particular shipment with minimal postage and a 5-month price. So you get a 6-month free. So obviously there's other products that patients can use. And if the patients have a fish oil, you get a bit of a challenge. And what I do with patients who have fish allergies is I ask them to use simply flaxseed oil, which is the vegetable source of omega-3s. Now, flaxseed is only about 40% as bioavailable for milligram to milligram equivalents of fish oil, but it's way better than nothing. It clearly doesn't contain mercury, and it doesn't contain vitamin E, which can be a consideration in perioperative patients where any thinning of the blood may be deleterious. We all take our patients off fish oil and vitamin E products because we don't want them to bleed when they're having major surgery. Cataract surgery, of course, is not influenced at all by anticoagulants, and I'll even do a retrobulbar in a properly selected patient who's on Coumadin. But if you're doing plastic surgery, anything on a vascular organ, you have to discontinue vitamin E, fish oil, and anticoagulants whenever possible. The sources of flaxseed are useful in both gel cap form and in powdered form that can be sprinkled on salads and oatmeal and cereals and various items like that. So finally, did the vitamin A increased risk of lung cancer similar to the findings with AREDS 2 in the age-related macular degeneration trials find confirmation elsewhere? And yes, there are other studies that show in cigarette users and even former cigarette users that the intake of beta-carotene is deleterious to your long-term risk for lung cancer. And AREDS 2 addressed that and did show that, and I think that we've all very rapidly adapted to the new recommendations of AREDS 2. AREDS 2 did not show any protection in AMD from omega-3, so those are no longer part of the recommendation. It did show that other carotenoids, such as lutein and zeaxanthin, are highly beneficial to patients seeking protection from progression of AMD and progression of dry AMD to wet AMD. And those formulations in the concoction called Macular Protect Complete, or MPC, from Science-Based Health are followed to the letter in these literature, peer-review, scientific trial-based formulations that you can get from Science-Based Health. So not only do patients obtain Hydro Eye from our practice, they also obtain the latest AREDS formula in the form of Macular Protect Complete. And you don't have to worry about what's new and what's the latest and what's the correct concentration, because Science-Based Health updates the formulations based upon current clinical science. So I think you've had a good clinical global approach. Obviously, tonight's topic can be the essence of a week-long seminar in greater detail. But clearly, dry eye is a centerpiece of any comprehensive or corneal eye care practice, and marketing and providing the best, most comprehensive, and sometimes cash-based services for your ocular surface disease patient is not only good for the patient and good for the doctor, but it's also good for the business as well. So everybody benefits. This is a win-win. Nutritional supplementation is extremely low risk compared to anything else that we do or recommend, and it's also equally extremely low cost. From a patient model, it's the first thing that I introduce, and from a business model, this is a high volume and very low profit margin business, but something that provides to the patient an added benefit. I've heard so many times that the patient says, I'm so glad you care about me as a person and the rest of me, and that you're giving me something that's not only good for my eyes, but it's good for my joints and my heart and my cartilage and my skin and my hair and everything else. Patients truly respect a doctor that doesn't focus on one organ system, but focuses on the patient as a whole. And not only on their medical condition, but their financial condition as well. So it's now 9:35, and I thank everybody for joining us for this hour and 4-minute seminar. I thank Science-Based Health for sponsoring such an unusual presentation, and for Karen Spencer's very practiced and insightful discussion of the business of running a dry eye center of excellence. So I wish everyone a good night and a low toxic and a high humidity environment and excellent nutrition and outstanding surgical outcomes and bottom line on your profit and loss statement in your business. Have a great evening. Keep in touch, and please feel free to contact Science Based Health if you have any further questions, comments, or inquiries.